Welcome, everyone. Today's topic is about medical and surgical management of corneal disease in small animals. Um, my name is Dr. Kasturi Barsavare. I am from India. I have 2 veterinary ophthalmology clinics in India, and I'm the moderator for today's session. It is my honor to introduce Dr. Marta Leva as our lecturer. Now, Dr. Leva is a European ECVO diplomate. Dr. Leva became an ECVO diplomate in 2005 after completing her residency training at University of Autonomous Barcelona. Since then, Dr. Leva has done her master's and her PhD in ophthalmology. Dr. Leva is currently working as an associate professor at University of Barcelona, and is an active member of examination committee, evaluation committee, and executive committee of her residency training at ECVO. She's an author of multiple international papers and has lectured in multiple national and international conferences. Welcome, Dr. Leva. I hand over the mic to you.
Okay, thank you very much, Kasturi. I'm going to share my screen. So first of all, I would like to thank Kasturi for inviting me together with Ambition, with Ingeborg Bromberg, for giving me the possibility to share with you this 2-hour lecture on corneal treatment. And then I would like to say that they told me that we have people of different level of knowledge. So I have prepared my lecture with some basic review of the cornea, but also some advanced surgeries that I would like to share with you. I hope that you enjoy the lecture. We're going to do like 2 stops in the middle. So you are allowed to make questions. I don't know if we will be able to answer all your questions because I know that you are a lot of people, but we're going to give like 5 minutes in every stop to answer your questions. And in case we don't have time enough, I will answer all your questions in writing in some days. So probably Ambition will, and Kasturi, or the organizing committee will send you all the answers so you can see your question answered. Okay, let's start then. As you all know, the cornea is the anterior portion of the fibrous tunic, and it is transparent. There has no blood vessels, no pigment, or no lymphatics. And these characteristics gives the aspect of complete transparency. It's a very well-organized structure that keeps in a dehydrated state, although the cornea is between the tears and the aqueous humor. Both are liquids, but the cornea stays in a very dehydrated state, what makes the cornea completely transparent. And for this, for keeping this dehydrated state, are very important 2 things. One, the epithelium, which is the external part of the cornea, that does not allow the tears to go inside the cornea. And in the other part, we have the endothelium, which is the internal part of the cornea, which will not allow the aqueous humor to go inside the cornea, and also will remove actively water or liquid from the stroma to the anterior chamber. One of the important things to know about the cornea is that we have a corneal thickness that goes between 0.4 and 1 millimeter, and that this corneal thickness is even thinner in the middle of the cornea. That means that if we have a corneal ulcer just in the center of the cornea, this ulcer is going to be more dangerous than if the corneal ulcer is in the periphery. So there's an important thing to remember, that ulcers in the center are more dangerous. And also we have to remember that this thickness varies between species, and we know that some brachycephalic breeds have a more thinner cornea than dolichocephalics and mesocephalics. And this is very important also because many of our patients are brachycephalics. So we go through a review on the anatomic and histologic structure. Remember that we have the anterior epithelium, the stroma, which is nearly 90% of the thickness of the cornea. Then we have the semen membrane and the endothelium. This structure is very similar to the human ones, but in humans they have two more other layers. They have the Duas layer, which is the basement membrane of the semen membrane, and we have the Bowman layer, which is the basement membrane of the epithelium. So we want to talk about these different structures: epithelium, stroma, the semen membrane, and endothelium, which is a very thin layer located between the cornea and the aqueous humor and the anterior chamber. So those are layers. Those layers are very important because when we talk about ulcers, we want to classify the ulcers depending on the depth. So we want to talk about epithelial, anterior stromal, medial stromal, deep stromal. Those ulcers that will affect the semen membrane. So you have a hole here, and this hole arrives to the semet membrane, and then corneal perforations. The innervation of the cornea is another very important point. In dogs, it has been described that we have between 30 and 14 branches of the trigeminal nerve, of the cranial nerve 5, that are innervating this cornea, and it gives us the sensation of pain to the cornea, but also helps in healing. And this is also very important because these nerves are located mainly in the epithelium and the anterior stroma, and the concentration of nerves are less in the center of the cornea. In fact, normally when we look to the esthesiometry, to mean to the sensation of the cornea, we know that the center of the cornea is less sensitive in many papers than the periphery. This is also very important because as the innervation is completely compulsory for the corneal healing, if we have an ulcer in the center of the cornea, we have previously said that the center is thinner and also is less innervated, we want to have problems in the corneal healing. Another important thing is that brachycephalic breeds has less corneal sensitivity than dolichocephalics and mesocephalics, and this is also very important. And remember, another practical point to remember is that as we have the nerves in the epithelium and anterior stroma, normally ulcers that are superficial are even more painful than the ulcers that are deep. So we cannot just trust on if an animal is in pain or not to know if the ulcer is improving or not. So we have to be careful with this point. Then we move into the corneal healing. The corneal healing will vary depending on the age of the animals. Of course, older animals heal more slowly than younger animals. The breed, we have seen that brachycephalic breeds have a healing that is more difficult, a healing that is more slow because of the corneal absence, or not absence, but reduction of corneal sensitivity in the center of the cornea. Then another important point is tears. So we need to have a normal quality and quantity of tears to allow a normal corneal healing. So we have a KCS. If we have a reduction of the Schmidt-Metrier test, then we will probably have problems in the corneal healing. Then again, eyelid anatomies. The anatomy of the eyelid, if we have eyelid malformations such as ectropion, entropion, eryblepharon, then probably the healing will be also affected. Blinking is also very important to help in the tears distribution. So for example, if we have a facial palsy, then we will probably have a secondary corneal ulcer that will need our help and probably surgery because the healing will be really affected. Then metabolic diseases, for example, diabetes mellitus or hyperadrenocorticism can be causes of healing that will be more difficult to see in this cornea. So you have to consider also metabolic diseases. So we have an animal that is brachycephalic, that has a central corneal ulcer, that is 14 years old, that has a KCS, and I don't know, that is diabetic, then we have a problem. The corneal healing will depend whether if we are talking on epithelium or stroma. in the epithelium, the cornea will heal by migration, mitosis and migration. And normally, the cornea grows in a rate of 0.5 millimeters to 2 millimeters per day. So if you see the size of the ulcer, you can more or less calculate how many days you will need to completely heal this cornea. And normally the epithelium heals without fibrosis, so you will see no scar after the corneal ulcer is completely healed. But when this ulcer gets to the stroma, things are completely different. The stroma healing is very slow. And you know that in the cornea, in the stroma, you have keratocytes and you have collagens, fibers of collagens that are really well arranged. And in case of an ulcer, those keratocytes will become fibroblasts or fibrocytes, and those fibroblasts will move into myofibroblasts. So you will have a scar and you will have a rearrangement and growth of new collagen. So you will have a scar. And this is very important to know that all the stromal ulcers, after they are completely healed, you will have a secondary scar, more or less severe, but a scar. Then the descending membrane. The descending membrane is the basal membrane of the endothelium, and it means that it grows and thickens with age. So in a very old animal, the semen membrane is thicker, as we can see in this picture, and in young animals it's very thin and elastic. So that implies that if we have the semetocele, an ulcer that goes deeply into the semen membrane, in a very young animal, as the semen membrane is elastic, it will bulge like this, but in a very old animals, it will stay in place, and there's still some thickness. So the semetocele, from our point of view, is more dangerous in a young animal than in an old animal. Then we have the endothelium. The endothelium is the last layer of the cornea, which is in direct contact with the aqueous humor. And it doesn't have mitosis capacity. So if you lose some cells within the endothelium, you will see how the other cells migrate and they make the cells bigger to try to occupy this space of the cells that have died, but there's no mitosis at all. As you probably know, we can take a look to the endothelium by specular microscopy. These two pictures are from our specular microscope, and you can see the endothelium of an eye of an animal with endothelial dystrophy in the left eye. This is the right eye. So you can see some cells that are starting to change in size, polymeratism. Yeah. And in this image, you can see the cells that are completely different sizes, different shapes, sorry. So with this image, we can say that there are problems in the endothelium, and we can confirm our hypothesis of corneal dystrophy. So it's a nice way of looking at the corneal endothelium in alive animals. You can also look at the corneal endothelium with stains, but this remains, but this implies an ex vivo or at least enucleation, because it's a stain method of histopathology. Then, I normally compare the cornea with the canvas of a painter. So in this canvas, it's completely white, and then you can see like different colors, and you can see blue, red, yellow, white, and black. And we need to interpret what means every color. So we see blue. Blue normally means edema. That means that there's a corneal hyperhydration, and normally this hyperhydration is in the stroma. And you will see how in a normal cornea, the arrangement of the fibers of the stroma, of the collagen fibers, is equidistant, each fiber. But when you have a corneal stroma that is hydrated, you lose this equidistance, and then the cornea gets completely cloudy. So normally, the edema is located in the stroma, but the origin can be completely different. It can originate by a problem in the epithelium, That means that you will have edema that comes normally from tears, or you can have a problem in the endothelium. That means that the edema will come from liquid that comes from the aqueous humor. And normally when you have a problem in the epithelium, you will see focal edema, like in this picture. So you can see that the edema is located in this area. Or if you have an endothelial problem, you will see how the edema is completely diffuse. That means that the problem is inside the eye, is not outside. So probably if we do a fluorescein test in these two eyes, we'll see that those eyes are negative, but this eye is positive, and probably this eye also. Red. Red in the cornea means normally vessels or some cellular infiltrate. And vessels, you have to remember that after the insult or the injury, they take like 4 or 5 days to appear, and then they grow in a range of 1 millimeter per day. And then the objective is to help the corneal healing. So they are not bad, they are helping. But the fact is that when we have the cornea completely healed, we want to remove these vessels because we want complete transparency of the cornea. So vessels are considered as a chronicity index, and we can differentiate those vessels in depth. So we can see with the slit lamp if those vessels are superficial or if are deep. And that means that together with the edema, probably the problem is located in the superficial layers of the cornea or in the deep layers. So if you have a slit lamp, by the appearance of the vessels, you can see that those vessels that are very similar to a tree are superficial, and those vessels that looks like a hair comb are are deeper. So for example, in this picture, those are superficial, those are deeper, superficial, superficial, superficial. That means that probably those eyes have a disease in the cornea in the more superficial layers of the cornea, and that this other eye has problems in the deep layers of the cornea or intraocularly. In this case, it was a glaucoma. Yeah? Then we can have yellow. Yellow means cellular infiltrate. It can be sometimes a little bit more reddish. So we know that the cellular infiltrate arrives through the limbal film, the limbus, or through the new vessels that appear in the cornea. And the cellular infiltrate is an index of chronicity. Again, they need days to appear in the cornea, and you can see how they can be a little bit more yellow, whitish, reddish, but are not blue. You have blue, of course, but you have yellowish. Look at that one. And here you have edema, diffuse edema, and there's an area where there's no edema. It looks like it's very, very thin. I always say that if you see the cornea with completely edema and there's one area of the cornea that is ulcerated and there's no edema in it, it's because there's nothing that can get edematomes. So be careful, because probably we have the semen membrane in here. Okay, so you can see this yellow infiltrate. And then we can see color white. White means lipidic deposits or calcium, calcareous degeneration. And again, they arrive through the lacrimal film, limbus, or neovascularization, and they can be also associated with an abnormal corneal metabolism. And again, they are considered an index of chronicity. But remember that in all the eyes, we can have the different colors all together, and we need to interpret what does it mean. And finally, we have the black color. The black color, again, arrives through the lacrimal film, the limbus, or the neovascularization, and is also considered an index of chronicity. And in cats, normally the black color means a corneal sequestrum, normally. And in dogs means pigment in the cornea, because corneal sequestrum is very, very, very rarely seen. It has been reported once or twice, a case report, but is not a normal condition. And then we have pigment that normally is associated with neovascularization, with cellular infiltrate, with edema. Or it can be also pigment that is inside of the cornea, because it's a uveal cyst, for example. So we will see some images later. With the slit lamp, you can differentiate where is this pigment located. So for me, the cornea is like a painting. So if you are in a museum, you are trying to interpret what you are saying, what you are seeing. So the eye is like a painting. So we need to interpret what does it mean. For example, in this eye, if we just concentrate on the cornea and doesn't look to the euroblepharon and conjunctival congestion, we just look to the cornea, we can see that this cornea looks okay, but in this area we have this color blue, that means edema, that is epithelial in origin because it's located in this area. We have some vessels that look like superficial because they look like trees. And also we can see that these edges of the ulcer are not attached, so it looks like superficial chronic corneal epithelial defect or spontaneous ulcer in this area. Okay, so we will try along the lecture, we will try to interpret all the images in the way that when we finish, we will be able to know what is edema, what is cellular infiltrate, what is the eye telling to us. So we want to continue with the diagnosis approach to corneal diseases before starting with the diseases itself. So we can have very different kinds of corneal diseases. Some of them are ulcerative, some of them are not ulcerative. Okay. We all know that we need to perform a complete ophthalmic examination. And I hope that you remember all the different steps of this ophthalmic examination. But perhaps from all the steps of a complete ophthalmic exam, there are some in which we need to pay special attention because they are really associated with corneal diseases, such as the Schirmatia test. With the Schirmatia test, you know that we allow those papers to be 1 minute in the conjunctival area. So the normal values for dogs and cats are between 15 and 25, and this is the more simple way of evaluating the tear film. But nowadays we have a lot more advanced methods for evaluating the tear film, and one of those is the meibometry or meibography. Also, we use meibography. Then we can have interferometry. We can look at the pH of the tears to look at the osmolarity. We can look at the meniscometry. We can look to the quality of those tears with a Ferning test or even with infrared thermography. So we have different tests that can be performed. And as the tears are very important for the cornea, we need always to evaluate at least the Schirmatia test. It's very important. All those tests, the Ferning test not, but all those are performed with this machine. The next step in our ophthalmic examination that is important for the corneal diseases is the slit lamp examination. You all know that with the slit lamp we have different lights. We have the diffuse light, the slit that is thick is 0.8, and the thinner one 0.1 or 0.2. Normally, we start with a direct illumination. With a direct illumination, we get those images in which you can see completely the cornea and you can evaluate the different colors. We can see in this case black, but we still don't know where is this black located. We can see the pupil is mydriasis, but the rest of the cornea looks nice. Some pigment in the conjunctiva, some vessels in there. And in here, we can see some corneal opacities, but we don't know still if they are fluorescein positive or not, or we don't know if there are cellular infiltrate or not. Then we move into the slit that is thick. So we do what we call a parallelepiped. So we get some images like this. Yeah, so with this light, you have the light here, you have the light here, and you are looking in this angulation, normally 35 to 40 degrees. And you can see how, if this is a section of the cornea, those opacities are located in the inner part of the cornea. That means that are located in the endothelium. Those are the same types of keratic precipitates, but in this area, you can see that they look white, and in the other area, they look opaque because it's an indirect light. direct high illumination. So you can see that the light goes into the iris, come back, and that is the reason why you see those images in black and those in white. But with this section, you can say that those abnormalities are located in the endothelium. Those are keratic precipitates. And the last part of our slit lamp examination is the optical section. With the optical section, we do very similar to the parallelepiped, but the light is thin, so we can do like an anatomic section of the cornea, and we can see that in this section, that is an optical section from your left to the right, you can see that this corneal epithelium is located also in the corneal endothelium. So it's a uveal cyst that has gone to the cornea. So you can see that this pigment is not in the epithelium. If it were in the epithelium, you will see the pigment here, but you see the pigment in there, so it's in the endothelium. And again, in this picture, you can see how those opacities, those white opacities, are located in the endothelium. This is an optical section from right to left. And in this image, you can see how the cornea is very thin in the center of the cornea after some superficial keratectomies in this dog. Here we have two ulcers, and you can see how with the slit lamp, you can say that those ulcers are very deep. Imagine this is the normal thickness of the cornea, and look here. Or it is at the cementocell or predecemetic. We have to test or to check with the fluorescein test. Then perhaps the last part of our complete ophthalmic examination that helps to the diagnosis of corneal diseases is the fluorescein test, the fluorescein stain. So you all know that the fluorescein will remain in the stroma, but not in the epithelium nor in the semimembrane. So with the fluorescein test, we will stain all the stromal ulcer or the epithelial ulcer, but not the corneal erosions. So you need to remove all the epithelium to have a fixed fluorescein test. But also with the fluorescein on the cornea, we can see another test that is Seidel effect. The Seidel effect means that there's a micro perforation in the cornea that is allowing the aqueous humor to go out and is cleaning. In fact, it's washing the cornea, and you see how it's washing the fluorescein in this area. You see aqueous humor going outside. That means that the cementocell has an area, a very small area of microperforation. But the fluorescein stain is not the only one that we can use for corneal diagnosis. We can also use rose or Bengal rose and lissamine green. Both stains allow to detect corneal erosions and conjunctival erosions. So for some very early stages of KCS, those stains can be very important because you can have a negative fluorescein test, but positive Bengal rose or positive lissamine green. You can use one or another. Both are very similar. Normally we have Bengal rose in our consultation, but punctually we can have also lissamine green in our patients. And those are diffuse stains in a very early stages of KCS. This is a human. Another important point in the diagnosis protocol of a corneal disease are the cytology. So you can use microbrush after a topical anesthesia drop. You do a cytology, and you can do a deep quick stain, and also the culture. The culture is very important for some ulcers. But you all know that the culture we need like 7 days more or less to have the results. So probably we will start working with the results of the cytology. So we will decide our treatment based on the results of our cytology, because we cannot wait 4 or 5 days to start with the medication. Then, Dr. Castri, I think it's time for a stop before we start with the non-ulcerative corneal diseases in dogs and cats. So perhaps we can answer some questions on the introduction, if there are, or if not, we can keep on.
So at the moment, we don't have any questions on the first half of the lecture. If anyone wants to ask any questions, please go ahead. I'm watching on YouTube as well. If I'm checking YouTube to make sure that we don't miss out on questions on YouTube.
Okay.
I think we should go ahead with the lecture.
Then we continue. Okay,
Yep.
Okay, thank you. We want to start with the most common non-ulcerative corneal diseases in dogs and cats. And as we have just 2 hours of lecture, I have selected some of them. So the ones that I think that are more important or are more commonly seen in our daily basis. So I want to start with our first case is Simba. Simba is a 9-year-old domestic short-haired cat, nature male, and the main complaint was a chronic corneal opacification of the right eye. The Shin-Mattia test was normal in both eyes, 18. The ophthalmic examination was completely normal. Menas response, nasal pupillae light reflexes, and palpebral reflex completely normal. Aqueous flare negative, that means that there was at least no signs of active exudative uveitis. Then the intraocular pressure was also normal. And then the fluorescein stain was positive in the left eye, negative in the right eye. So it has to be the other way, sorry. So it was positive in the right eye. So you can see in this area that we have cellular infiltrate with vessels, and also there's some stain in the cornea, that this stain affects mainly the area in which we have the cellular infiltrate. So really, there's not an ulcer in the cornea, but there's an area of overgrowth of cellular infiltration that has no epithelium above, and that's the reason why it stains with fluorescein, but it's not really an ulcer. Mm-hmm. So with this clinical presentation, we probably all think about one disease that is the let me see, that is this, the eosinophilic keratitis. And the eosinophilic keratitis, in some cases, can have positive stain of fluorescein, like in this image. You can see that stains the cellular infiltrate and also this area of superficial ulcers. Mm-hmm. And if you have suspicion of eosinophilic keratitis, you need to go to do a cytology. And if you see one eosinophil, that would be enough to diagnose the eosinophilic keratitis. And there are papers in which nearly all the animals with keratitis, with eosinophilic keratitis, has had eosinophils in their cytology. So it's a very relevant clinical point. So if you see this eosinophil, you have the diagnosis. And then we really don't know which is the triggering condition of the eosinophilic keratitis or keratoconjunctivitis, but there are some authors that talk about the herpes virus as being the cause, or at least having some role in the appearance of this eosinophilic keratitis. But honestly, the studies are not completely definitive, so there are some controversies on this. And the fact that many of those animals respond really well to the topical medication with corticosteroids, that makes us think that probably the condition is not truly caused by a herpes virus. So although we all know that if we do a PCR that is not quantitative, is a qualitative PCR in a normal cat, probably it will be positive. We need to have studies with quantitative PCR of feline herpes virus in cats with eosinophilic keratitis to make sure that of the role of the herpes virus in this disease. And those studies are not published yet. So the treatment, we normally start with 0.1 dexamethasone or 1% prednisolone acetate in drops, 3 to 4 times a day. And we have a really good results with this medication, but there are other papers that have been published in which you can use also 1.5% of cyclosporine. For example, if you see an animal that has a really bad epithelial ulcer, and you think that probably there's some herpes virus here, and you don't feel comfortable to use topical corticosteroids, for example, you can start with cyclosporine, with topical antibiotics and antiviral drugs if needed, or even with non-steroidal drugs if you don't feel comfortable to use cyclosporine. And then when you have this cornea completely fluorescein negative, you can move into topical dexamethasone or topical prednisolone. Another option is the topical megestro acetate that has been described in a 0.5% with really good results and no effects at all or systemic effects at all. So it's a good option also. And there are other studies on the use of mesenchymal stem cells, but those stem cells are very expensive. And I think that if we have treatments, 2 or 3 treatments that work perfect with no topical, with no local or systemic effects, we don't need to use more expensive treatments. But at least we need to know that there are some researches going on this subject. So with the first case, we need to remember that if we think that we have a case, or we are facing a case of eosinophilic keratitis, we need the cytologic confirmation of the cornea. If we see one eosinophil, that would be enough. That we can use topical corticosteroids besides we have some mild staining of the cornea, because normally this stain is above the cellular infiltrate, not in the cornea itself. But if you don't feel comfortable, you can move to non-steroidal drugs until you have a negative staining. And there are other treatment options if you want to try. And you have to inform the owners that they will need to keep the treatment at least for 1 month, and then we will taper the medication slowly. In our clinic, we don't test for feline herpes virus PCR in those cases, but in case you would like to, I recommend you to perform a real-time PCR, which is a quantitative PCR. So we want to move to the second case. This is Neko. It's a 7-year-old domestic short-hair cat. Is a neuter male, and the main complaint is changes in color of the cornea. The Schimatia test is normal in both eyes, so it's between 15 and 25. The neuro-ophthalmology is completely normal. So see, there's no alterations. The aqueous flare is negative, and intraocular pressure is normal, but we have a fluorescein stain in the right eye. When we look to both eyes, we can see that there's black color in both eyes. Okay. Is more mark in the right eye than in the left one, and there are also some superficial vessels, some edema and cellular infiltrate around this sequestrum, and probably we can have in here, and in fact we had some mild fluorescein staining, but the eye looks okay apart from the cornea. So here you have another case in which we have a corneal sequestrum with a very important cellular infiltrate with neovascularization. You can see that is a superficial neovascularization, and this area of fluorescein stain that is not affected the sequestrum, but an ulcer that is surrounding the sequestrum. So we have to be careful in this area, because perhaps we have herpes virus, perhaps we don't. The sequestrum is a corneal necrosis of the affected area that is normally affecting the central cornea, and there are different studies in which we can see that there are no porphyrins in this sequestrum, but there is melanin. So there's pigment in this sequestrum. Normally they are affecting the superficial parts of the cornea, but they can go deeper and even induce corneal perforations. The breeds that are more affected are the Persian, but all the brachycephalic breeds are predisposed to have this corneal sequestrum. And also it has been associated with a reduction in the corneal sensitivity. And as we all know, the brachycephalic breeds of cats have less corneal sensitivity than the non-brachycephalic breeds. So it can be a predisposition for for corneal sequestrum also. There's also a case report in which the corneal sequestrum was completely mineralized. So the aspect was not black, but was white. It's a curiosity. Those animals, normally, we always test for tears abnormalities, not only in quantity, but also in quality. And there's a very interesting paper of Fran of 2005, in which they were comparing the quality of the tear film and the conjunctival globate cell in cats with corneal sequestrum. And what they saw is that statistically, there were no differences between normal cats and cats with sequestrum. But if we look at the numbers, we can see, for example, that the breakup time was 21 seconds for normal eyes, but 14 seconds for the corneal sequestrum. So statistically, there was no difference, but for me, clinically, there's a difference. So you have to choose whether if you apply artificial tears or not to those eyes while you are waiting for the surgery, because we all know that those eyes need to go into surgery. But we think that it's important to give some artificial tears that allow this mucoproteic layer of the cornea to be reinforced, to improve. And normally we give hyaluronic acid. So in this table is a table of the Slater Veterinary Ophthalmology book. In chapter 9 is a chapter that we wrote some years ago. You have a very nice table in which you have all the different tears that you can find commercially available and the indications for each one. So you know that if you have tears that are isotonic with high viscosity, and you would like to increase the tear film breakup time, then you can use the methyl cellulose. And in those animals, we think that the most indicated tears are the hyaluronic acid. So we apply hyaluronic acid while we are waiting for the surgery to be scheduled. Again, there's an association with herpes virus and the corneal sequestrum, but we have the same situation. There are some papers in which they say that there is a real association, others that not. So we really don't know what is going on. Apart from the corneal sensitivity that we have seen that is reduced in brachycephalic breeds, as you can read in this paper, there are other eyelids abnormalities that can affect this cornea, such as the distichias or the eryblepharon. So we need to be aware of these abnormalities also, and we need to fix the corneal problem, but also the eyelid problem. So the gold standard treatment for this disease is superficial keratectomy, but we all know that this sequestrum can be spontaneously extruded, but it's very rarely seen. What they normally do is to go deeper and deeper, and they perforate the eye. So our recommendation is not to wait. So if the owner wants to wait, perhaps we give some artificial tears, psychoplegic, non-steroidal drugs, and antibiotics until they want to do the surgery. But we have to inform the owners that is not the treatment of choice. The treatment of choice is surgery, and there's a superficial keratectomy. Again, look in this eye. We have the corneal sequestrum in here. Look at the vessels that are very superficial, but look here in the projection area. There's a distichia. So we need to go do also surgery on this area if we want to fix definitively the problem. So talking about superficial keratectomy, you all know that is the excision of a portion of the cornea. So we have the sequestrum in the superficial areas of the cornea. We remove the superficial areas and we eliminate the disease area. The main disadvantages are that you decrease the corneal thickness and it will change the corneal refraction and vision. And also another disadvantage is that if you go very deep, deeper than medium stroma, then you will need some tectonic support and you will need other kinds of surgery to improve the thickness of the cornea. Because if you allow to heal a very deep ulcer you can have by secondary intention, then you can have problems. So it's better to give some tectonic support in different ways that we will discuss later. Corneal grafts, conjunctival grafts, keratoplasties, corneoconjunctival transposition, biopsies, amniotic membrane. There are very different ways of giving some tectonic support. The indications for a superficial keratectomy are a lot. So you can use it, of course, for a corneal sequestrum, but also for corneal biopsy, for a spontaneous chronic corneal epithelial defect, but is very rarely used right now because we have other surgical treatments that works and are less invasive, or in infectious keratitis, corneal abscesses, corneal dermoids, like in these pictures, corneal tumors, inclusion epithelial cysts. Look at those are epithelial cysts, or as a stage of the corneoconjunctival transposition. So it's a very useful surgery that all the corneal surgeon need to know and to master, because it's a very common one. The procedure consists in separating the lamella of the stroma, not to cut, but separate them. And you have to stay in the same plane if you want to avoid a corneal scar. So you have to be in the same layer of collagen fibers to keep the cornea completely transparent. So we normally start with a tree fine that is rounded of different sizes. So you have to measure before and you select your tree fine if the lesion is rounded. And if it is not rounded at all, you can do a freehand with your beaver blade 64. And then you continue with the beaver 65, the beaver blade 65, which is here, or with a razor blade in a treatment here, in here, or with the crescent blade. This is my favorite one, or with the Martinez dissector, or even with scissors with rounded tips. So you can use those different surgical instruments to perform a superficial keratectomy. So you can choose. My favorite one is the beaver blade 64 to mark, and then the crescent. So it is considered a very basic procedure in ophthalmic microsurgery. So all of the people that is performing corneal surgery need to master very easily a superficial keratectomy. So we need to handle tissue we need to handle the tissue very gently, and we need to maintain dissection at the same level. And appreciate the depth of the dissection. This is the more difficult step of the surgery. And in my experience, this is the more difficult part to teach to our residents. That they know if they are in the anterior stroma, mid stroma, or deep stroma. And you only can teach this, or you can only learn this with experience. So we want to see one video of a corneal sequestrum. So first you measure, it's a big sequestrum, you measure, you select your corneal tree fine, you start your lamellar keratectomy, and as you see there are some remnant of pigment, but we keep the pigment here and we prepare the donor in this case because we know that we were going very deep of the cornea. We remove the remnant of pigment and then we place the cornea. It was a frozen pig donor eye. And we always select the donor 1 millimeter bigger than the receptor bed. And we suture with non-observable suture in an interval pattern. We place first the cardinal suture points and then the rest. And then we can also use the superficial keratectomy for other kinds of corneal diseases, such as the squamous cell carcinoma or a corneal tumor. In this image, we can see a superficial keratectomy to treat superficial carcinoma, squamous cell carcinoma. And you can see how in this video we are using a crescent blade. This is my favorite. And the crescent blade works really well because it keeps you in the same plane, in the same layer. So you have less possibility to go deeper than with the other, with the 65 blade. So you have a completely transparent cornea. If the superficial keratectomy, if the keratectomy is superficial, that means that it affects the anterior stroma, then there's no need for tectonic support. But if you go to medium stroma or if you go to deep stroma, then you will need tectonic support, as we have seen in this video of this corneal sequestrum. So if you need tectonic support, you can use Corneal, as we use in our service. We normally use Corneal. The corneal healing of cats is incredible, so you have really good results. As you can see in our paper published in 2015, we have very nice results after corneal sequestrum surgery. But you can also use amniotic membrane, or you can use biopsies, or you can use urinary bladder acellular matrix with good results, or even you can use corneoconjunctival transposition. But with this surgery, the main disadvantage is that you are injuring a healthy cornea, and you are inducing a peripheral opacity with the conjunctiva in this area. But you can see how the axis is completely transparent in this cat, not in that one. Here is the limbus. Okay, and also there's a paper talking about the use of cyanoacrylate adhesive for the treatment of feline corneal sequestrum. But in my experience, these adhesives work when the lesion is very superficial but not deep. With a deep ulcer, you have a risk of corneal perforation after the use of this cyanoacrylate adhesive. So it could not be my choice at all. So I will go always for a corneal graft if the superficial keratectomy is deeper than the medium stroma. What more? Well, if there are other options that honestly I have not tried, but it has been described the use of the diamond board, which is this machine, to do a superficial keratectomy for treating calcareous degeneration or even pigmentary keratitis. And you can use also, because it's very similar, you want to remove the superficial layers, you can use this diamond burr for the treatment of very superficial and initial corneal sequestrum. And in fact, in Spain, there are some colleagues that are using this technique with good results. But as these results have not been published yet, I cannot recommend this technique, but hopefully they will publish the results as soon as possible, and then we will all be able to use it if the results are good. So there's another option to consider. And after the superficial keratectomy, if you are not going to give any tectonic support because it's superficial, then you can use some corneal lenses. In the market, there are two different commercially available lenses: the ones that are commercially available for veterinarian, and the ones that are from human beings. So you have those are the ones commercially available that are sold by Envision, and you have here the ones that we use regularly if the lesion is very small, because they are very small. But if the lesion is bigger, then you will need to go for those because they cover the complete eye. But perhaps the main disadvantage of these lenses is that you need to know the size. So normally what we do is to have 2 or 3 sizes at the hospital, and then we move between these 2 or 3 sizes because you cannot have all the sizes. So talking about corneal sequestrum, then we will know that they have an unknown etiology. Perhaps it's herpes virus, perhaps no. We have some less corneal sensitivity. We have erythema. We have some dystichia. So there's something complex. It's not a simple etiology. The gold standard surgical treatment is the superficial keratectomy, or not superficial, plus tectonic support. And then while you are waiting for the surgical treatment, you can start treating the eye with antibiotics, broad-spectrum antibiotics, non-steroidal drugs, artificial tears, such as hyaluronic acid, and psychoplastic drugs. And we really don't know at that moment the role of the feline herpes virus with the corneal sequestrum. The third case, we have Conan. Conan is a German Shepherd, 5-year-old male. And the main complaint is corneal opacification. So we have a Schirmer tear test that is normal. And the neuroophthalmology is nearly normal, except for the menace response that is not complete. And then we have the aqueous flare is negative, the intraocular pressure is completely normal, and then the fluorescein stain is negative. When you look at the cornea, you can see that it's not transparent anymore. And if we identify the different colors, we see black, we see, that means pigment, we see some blue, some edema, we see some vessels, red, that are very superficial in both eyes. And the opacification is in the lateral part of the cornea, in the temporal part of the cornea. So if you see this in a working breed, probably it will mean that you have a chronic superficial keratitis, pannus, or a uveitis syndrome. All those terms are synonyms. So if you have the suspicions of chronic superficial keratitis, you need to perform a corneal cytology again, and you will see how in your cytology you will see lymphocytes and plasma cells. So you will confirm your clinical suspicions. And there are some studies that say that those lymphocytes are CD4 positive. When we have to decide the kind of treatment that we are going to apply, normally what we do is we grade the pannus in different grades depending on the degree of opacification. So if we have less than 1 quadrant affected, then we will see that we have stage 1. If we have 2 quadrants affected, or one or 2, then that means that we are in the stage 2. And if we have 3 or more, then that means we are in the stage 3. So it will help you, this classification, to decide not only the kind of drug that you are going to use, but also the posology, if you're going to give more often or not, if you're going to give twice per day or 4 times daily. In some animals, you all know that the pannus can be associated also with cellular infiltrate of the third eyelid that is called plasmoma. And you will see some depigmentation of the third eyelid with the presence of some follicles and thickening of this structure. So the most common treatment for this condition is 0.1 dexamethasone or 1% prednisolone acetate 3 or 4 times daily. It will depend on the degree of the disease. You can start, if it is very mild, with 2 times and up to 4 times. And if the disease is very severe, starting to be stage 3, you can combine topical corticosteroids with cyclosporine, both things together. If the animal or the owner cannot treat the animal 3 or 4 times daily, you can always use subconjunctival corticosteroids, but the problem of this depot is that it stays subconjunctival, and then if you have a problem or you have a corneal ulcer, you cannot stop the absorbance of these corticosteroids, and you can have problems. But it is another option. Another treatment that I would like to share is the radiotherapy. Is a very soft radiotherapy with which Dr. Algoever obtained really good results, but in a short term. And then cryotherapy, same, with good results, but in short term. So that means that you can treat those eyes, but you need to keep on with the medication. Otherwise, the disease will appear again. And we all know that this disease is an immunomediated disease that is associated with higher altitudes and lower latitudes. So, if possible, we would like to protect those eyes to the UV radiation. And if the owner wants and the dog behaves okay, we can use some sunglasses to protect from the UV radiation, or at least to avoid hours between 12 and 4 o'clock in the midday here in Spain, because those are the very more dangerous hours of sun for those animals. So normally those cases will start in Spain in April, May, and will remain until September, October. And the thing is that we need to inform the owners that this disease is very chronic. So they will need to treat the eye during all the animal lives. Is something very different from the eosinophilic keratitis of cats. With the feline eosinophilic keratitis, you treat the disease and normally it disappears. It can regrowth or reappear, but it's very, 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 very rarely seen. With the pannus, that means it's a chronic disease, and we need to inform the owners. Otherwise, they will feel very depressed, because when they stop the medication, that disease starts again. Similarly, of what we have talked about, the use of diamond borer for the corneal sequestrum. In fact, it has been published for the treatment of pigmentary keratitis. This is not a pigmentary keratitis; it's a superficial chronic keratitis. That means that it has an immunomediated cause. But I think that we can use also the diamond borer debridement, at least to remove the pigment that is on the cornea at that moment, and then start with the treatment to avoid pigment to appear. So it's easier to remove this pigment with surgery than with medication, but we need to make sure that medication has good results. So what we do is we start with medication, and when we see that the eye improves and the pigment is not disappearing anymore, so we are not improving. We have improved, but now we are stopped the improvement. Then it's time for the surgery. So we remove all the pigment and we keep on with the medication. When you remove the pigment, you have a corneal ulcer. So while this ulcer is healing, we don't give topical corticosteroids, but we give cyclosporine and, of course, antibiotics and cycloplegics. And once the ulcer is completely healed, then we start again with topical corticosteroids, and we have really good results also with this approach. There are some papers talking about the use of UV blocking contact lenses in these animals, but the results were not good, so I really don't recommend those corneal lenses in those cases. Then, similarly, I can suggest the use of cyclosporine implants in the episclera or subconjunctivally. In fact, there was a pilot study published by Dr. Barracetti, in which she was using those implants for the treatment of KCS in dogs. That means tear deficiency, and it worked. It was a pilot study, but seems to work. And we use those implants of very similar for the treatment of superficial corneal diseases in horses, and they work. So probably they could work in dogs, but there are no studies at the moment showing that those results are good. So probably in some months we will have those studies published, but not yet. But it could be an option, and it's very interesting because this will allow to diminish the medication or even to stop the medication. This is our hypothesis. So the take-home message from this paper is that if you have the clinical suspicion of chronic superficial keratitis, you need a cytology confirmation. That this disease needs long-term medication, and there's no complete resolution at all, and the owners must be aware of this condition. And what we give is an informational brochure for owners, so they have all the information here, and we make sure that they have read the information, and they know that they have to treat those animals for all their lives. And then the surgical treatment is an option, but only when we have seen that medical treatment improves a little the situation, because we need to keep with the medication after the surgery. So it's not that you do the surgery and you forget completely about the disease. No, you do the surgery, but you keep on with the medication after the surgery. Then case 4. Case 4, we have Lola, is a pug female, 3-year-old. The main complaint is eye opacity. And we can see this pigment in both eyes. The sheet material is normal. The Menas response is a little bit diminished. All the rest of the neuro-ophthalmology exam is completely normal, as well as intraocular pressure. And you see this pigment that is not affecting the complete cornea, but the medial canthus with some vessels and some edema. So we call to this disease pigmentary keratitis, a very typical disease of the pugs. And in fact, there's a paper talking about the most common risk factors for corneal pigmentation in those animals. And from our point of view, there's a predisposition for pigmentary keratitis because of the eyelid predisposition and the corneal predisposition. So we have those animals with a very shallow orbit with an eyes that are very exposed, and we have eryblepharon with lagophthalmia. In some animals, we have nasal folds. Those nasal folds makes that we have medial entropion in this area. That is even worse because, as we all know, the medial palpebral ligament is fixed to the frontal bone in dolichocephalics and mesocephalics, but in brachiocephalics, this medial palpebral ligament is fixed to the nasal bone. That means that the medial canthus is inwards. So we have to correct this problem if we wanna fix the medial entropion. Because if you do a medial canthoplasty or you do a nasal fold resection, but if you don't cut this medial ligament, you will not be able to fix the medial entropion. And this is because of this, because they are fixed to the nasal bone instead of the frontal bone. And then we have caruncular trichiasis. You see here the medial entropion with the hairs. And then we can have caruncular trichiasis, where you have long hairs coming from the caruncle and touching the cornea that can worsen the clinical presentation. It's important, the term pigmentary keratitis, because some years ago we were classifying the disease as pigmentary keratopathy. But in fact, there are some papers, mainly this one, in which they were doing confocal microscopy in those animals, and they saw that those corneals were also affected with vessels and with cellular infiltrate. So we need to reterm pigmentary keratitis instead of pigmentary keratopathy. So it's an inflammation over here. In a similar way to the superficial chronic keratitis, we can classify the pigmentary keratitis in different stages, 1, 2, or 3, depending on the distribution of pigment. And the treatment approach in our hands, we always start with medical treatment, and we give a combination of anti-inflammatory drugs. We would like to give corticosteroids, but if we have very severe eyelid problems, we prefer not to give them because we can have secondary corneal ulcers. So we go to non-steroidal drugs in combination with cyclosporin, tacrolimus, or sirolimus if we want, and artificial tears in ointments just to avoid those hairs touching the cornea. And we give some months of this medication to remove completely the vessels and the cellular infiltrate. And once we are sure that there's no more improvement on the pigment reabsorption, we go to corneal surgery and eyelid surgery. And in some cases, we combine both surgeries. For an eyelid surgery, normally those cases in our hands are treated by medial canthoplasty by a technique that was described by Dr. Ingrid Alweber, in which she was moving or displacing the medial punta, lacrimal punta. So it allows you to section as much tissue as you want because you are preserving the punta. So we have such a nice results in all our patients, and they work perfect. And remember that when you do the medial canthoplasty, you need to cut the medial ligament. And we combine with debridement of the cornea. you can see in this video, we are using the diamond burr and we are removing the pigment of the cornea. And you can see how the tip of the diamond burr is stained with black, and we are removing all the pigment. You see the vessels. So it is really a keratitis. We remove of the pigment, we place a bandage lens. Normally we use Envision corneal lenses for these conditions because they protect all the cornea. And if you want to make sure that the lens stays in place, you can do a lateral tarsography temporarily to make sure that the lens stays in place. So you have those results. And after the superficial keratectomy with the diamond burr, you start with topical medication, but non-topical corticosteroids. You don't give topical corticosteroids until the cornea is completely healed. And then once it's healed, it's present negative, you start again with topical corticosteroids. Now that you have the cornea and the eyelid problem resolved with the surgery, or both things. So regarding this disease, an early approach and a preventive treatment is compulsory. We need eyelid surgery plus, probably in some cases, if it is very, very severe, the disease, and is affected the corneal axis, then corneal surgery. Of course, we don't do corneal surgery if the pigment is very mild and is not affected the corneal axis. Then topical medication and plus minus the corneal surgery. The etiology is still unknown, but there are multiple factors, and some of them are in the eyelids and in the cornea itself, the corneal exposition and less sensitivity. And then inflammatory disease, we need to give some anti-inflammatories because there are vessels and inflammatory cells. And the prognosis is poor for vision if the disease is very advanced. Of course, if you have a cornea completely pigmented, like in this pack, it's very difficult to regain some transparency. But so surprisingly, normally you see how the pigment is not so dense, is less dense than before, and the animal starts to have some menace response, although you don't know how, but some of them present menace response. So I think it's worth to keep on with the medication, and if the owner agree to go for corneal surgery, at least to give some vision to those animals. Then Castri, I think it's time for a second stop and some questions. Let's see if we have 5 minutes for questions.
So we have multiple questions. We have, as you said, that we have only 5 minutes. I'll only ask. We will provide all the answers later. Dr. Leiva will answer them later. So one of the questions was, do we need to prescribe antivirals along with cyclosporin 1.5% in order to treat eosinophilic keratitis? So do we need to prescribe antivirals along with cyclosporin?
With the eosinophilic keratitis, you mean?
Yes.
No. Normally we don't do. I know that some people
okay.
do, but as the relation between the eosinophilic keratitis and the herpes virus is not really confirmed, I would not go for this treatment. If I have a really suspicious that there's something going on here, then probably I will do a cytology and I will ask for a PCR of herpes virus. And then if the PCR is positive, I mean a real-time PCR, then I will treat with antivirals. But if not, yes. I have been treating all the eosinophilic keratitis in my life. That means a lot and a lot. I have not seen any problem. So I go directly for topical corticosteroids or non-steroidal drugs if I see that there are some mild ulcers. And then when the ulcers are completely healed, we change to topical corticosteroids. Normally, our first approach in eosinophilic keratitis is topical corticosteroids. But I know that some people also use cyclosporin. We don't.
Now, this second question that I would like to ask is, would you after superficial keratectomy, would you do a third eyelid flap?
This is a good question. I think that there are two kinds of ophthalmologists: ones that perform third eyelid flaps and the ones that don't. And I belong to the second group. Normally, we don't perform third eyelid flaps because I would like to see what is going on there. So if we treat the infection, if we give all the good conditions to heal, then probably it will go okay. Then I think that we can do something similar instead of with the third eyelid flap with the bandage lens. So you can place a bandage lens. You can do a lateral tarsorrhaphy to make sure that the lens will be in place, and you can see what is going on. Because we all know that normally everything goes well, but there are some cases in which you remove the third eyelid flap and you have a melting, you have a corneal deeper ulcer, you have a corneal perforation, and I don't want this with my patients. So I will say no. We don't do third eyelid flaps.
Okay, and so there are a few questions about would you use tacrolimus in PANIS or chronic superficial keratitis cases?
Yeah, you can use it. Yeah, I mean, the cyclosporine and tacrolimus share some part of their mechanism of action. You can use both tacrolimus, cyclosporine, or sirolimus if you want. The three of them, yeah, with which you feel more comfortable, but in combination with dexamethasone. What we do is we start with both together, and once the disease is under control, we remove the corticosteroids and we keep with cyclosporine because it has less secondary effects on the cornea.
Okay. There's one question about anhypro gel. Do you use anhypro, and how do you like it in pigmentary keratitis or dry eye cases?
It's perfect. And I think it's a more concentrated artificial tears of hyaluronic acid that we have in the market. And I really like them, and I use them not only for pigmentary keratitis but also for corneal sequestrums because I think it helps. So if you look at this table that I have shown you, if you go to the Slater book and you see our table, you will see that hyaluronic acid is very indicated in many corneal diseases, and sequestrum and pigmentary keratitis are two of them.
Okay. So should I continue asking you questions because there's like a flood of questions, or
both? And then if we have time at the end, because I want to make sure I can finish with the lecture, and if we have more time at the end, we can go to those questions. It's okay for you?
Okay.
Okay, let's continue.
Sure.
Then let's go to corneal ulcers. So the dog has a corneal ulcer. What should I do? Then first is to localize and remove, to look for the cause. This is very important. It's not just, ooh, fluorescein positive, ooh, there's a corneal ulcer. No, we need to look for the cause. So we can have a KCS, we can have eyelid malformations, we can have entropion, ectropion, eryblepharon, we can have mineral deposits, we can have calcium, we can have ectopic cilia, distichia, dystrichia, trichiasis, 4-inch bodies. We can have a chronic trauma due to an eyelid tumor, for example, that is touching the cornea. We can have infection with bacteria, with fungal, with algae. So we need to know what is going on here to choose the most appropriate treatment. This is very important. So we can have ulcers induced by distichia, by ectopic cilia, infected ulcer associated with medial entropion. Look at the area where this ulcer is located is the lower medial cornea. So normally those ulcers are associated with a problem or the third eyelid or the medial entropion, 4-inch bodies. So we need to look for the cause. Normally in our hands, in the nearly 70-80% of cases, we find a cause. Then we need to go for the ulcer classification. And once we have the classification of the ulcer, we can decide which is the most appropriate treatment. Look at the pictures, are very nice. Right? Sorry. Superficial, corneal perforation with calcareous degeneration, superficial with non-attached edges, the cemetocell, superficial with non-attached edges with cataract. It's very nice picture. So let's talk about the practical classification and our treatment protocols for corneal ulcer. Of course, there's not just one protocol that works. There are many protocols that can work. I want to share with you our protocol. So there are plenty of very different ulcers that we can have, more superficial, deeper, infected, non-infected, associated with anterior uveitis, with no anterior uveitis, located in different places. And we need to classify those ulcers to make us to classify in a way that we all can understand each other, and that we can get the image in our mind just with the information that you are giving to me. So a complete classification will talk about if these ulcers are acute or subacute or chronic, about the depth. So we're going to talk about erosions that affects the epithelium. That means fluorescein negative, but Bengal rose positive. Epithelial ulcer, anterior stroma, deep medial stroma, deep stroma. The cemetocell, remember that the cemetocell will stain just in this area, in the margins, but not the bed of the ulcer, because this is the semimembrane and do not fix the fluorescein. And then the corneal perforation with saddle effect. And then the location, central, paracentral, or periphery. Remember that the central ulcers are more dangerous than the peripheral ones. Size, more dangerous, the bigger than the smaller. Then reflex anterior uveitis. We can have anterior uveitis that is not exudative or exudative. Then the etiology, we can have traumatic, eyelids abnormalities, hair abnormalities, foreign bodies, idiopathic, we don't know what is going on. And then the last part, but not the less important, is the infectious. I mean, if this ulcer looks like infected or not, or if this ulcer is melting or not, there's a keratomalacia. So with this kind of classification, I'm going to talk about this ulcer. If you see this image in the upper part of the screen, I will describe this image as a chronic central 3 millimeter cemetocell with a microperforation, and I know that is perforated because this saddle effect. And this picture will describe by saying that is a chronic peripheral 6 to 8 millimeters epithelial ulcer with non-attached margins. So you can see how the fluorescein stain is above the epithelium in here. So we will see that this ulcer is a superficial chronic corneal or spontaneous chronic corneal epithelial defect. This is a complete classification of the corneal ulcer, but if we are general practitioners and we want to make it easier, we can do a practical classification that divides the ulcer into 2 groups. The simple corneal ulcer, that means that this kind of ulcer is not associated to anterior uveitis or are epithelial or anterior stroma. And then we can have complicated corneal ulcers, in which in this group we find the spontaneous chronic corneal epithelial defect, the infected ulcers, melting ulcers, deep stromal ulcers, the cemetocell corneal perforations, and those ulcers can be associated or not with secondary uveitis or reflex uveitis. But normally, the more severe the ulcer is, the more possibility to have reflex uveitis. Well, let's start with the management of simple corneal ulcers. Simple corneal ulcers, as we have described previously, are those that affect the epithelium or the anterior stroma with no non-attached margins. So you see that the margins are in place. If you have any doubt, just place a drop of topical anesthesia, and with a cotton swab, you try to remove the margins, and you will see that they remain in place. So you don't have non-attached margins on this ulcer. There's no cellular infiltrate, so that means that there's no white color. We can, in a simple ulcer, we can just have red color, that means it's a chronic ulcer with some vessels, and blue color, that there's edema, but not cellular infiltrate. If there's cellular infiltrate, then it's a complicated ulcer. And no secondary uveitis with no aqueous flare. Those are very simple corneal ulcers. Our treatment approach in those ulcers, again, to identify and remove the cause. So you need to look for the projection area. So if the ulcer is in the medial canthus of the cornea, go to the medial area and look in deep to this area to make sure that there's nothing. If it is in the upper part of the cornea, look for ectopic cilia or a distichia in this area or a foreign body. But if it is in the upper part, don't go to the lower part to look, because this is not logical. And then we initiate the treatment with broad spectrum topical antibiotics to prevent infection. And then you can use triple antibiotic of fusidic acid, for example. And then we use cycloplegic drugs or atropine or cyclopentolate. We all know that atropine reduces the Schirmer-Tear test, but the cyclopentolate, no. Our team presented studies some years ago. So you can use cyclopentolate in cases where you have an ulcer and a KCS. And then the Elizabethan color. I know that many people use other kinds of drugs apart from those, but I think that they are not needed. In a simple ulcer, if you fix the triggering condition and you give topical antibiotic, cycloplegics, and perhaps some artificial tears, and you put an Elizabethan color, is enough. If the simple corneal ulcer has not healed in 72 hours, then there's something going wrong. But perhaps it's the cause is still there, that the ulcer is infected, that the ulcer is deeper, or then you have a spontaneous chronic corneal epithelial defect. In any of those cases, we are facing a complicated ulcer. And the clinical approach is completely different. So in the management of complicated corneal ulcers, so in this picture, look, we have this area of edema is diffuse. In this area, there's no edema because there's a Desemeto cell. We have, in this case, superficial neovascularization and cellular infiltrate. So we have infected ulcer, and probably if you touch this cornea, you will see that it's melt. Probably is a melting ulcer. Let's continue with our fifth case. We have Horus, a Chihuahua, 5-year-old male, and the main complaint is blepharospasm of 5 days in the left eye. If you take a look to the Schirmer, you see how in the right eye is 18, but in the left one is 25. When there is a difference of bigger than 5 points, that is significant. There's something going on. And the same for the intraocular pressure. If you see a difference bigger than 5 points, there's something going on. Now, ophthalmology is completely normal, except for the fact that there's a meiosis in the left eye. The aqueous flare is mild in this eye, so that means that we have anti-uveitis, reflex anti-uveitis in this eye. And the intraocular pressure, if you look at both eyes, there's an important difference between both. So that means that we have exudative anti-uveitis in the left eye, and the fluorescein test is positive. And if you look at the image, we can see that the margins are not attached. So we have here are not attached. You see how the fluorescein is underneath the corneal epithelium. So we are facing probably a spontaneous chronic corneal epithelial defect associated with anti-uveitis. If you are not sure, topical antibiotic, and you check with your cotton swab, always with magnification loops, if possible, is much better. And then if you confirm your clinical suspicions, then you can explain the owner what this kind of ulcer means, and you will know that there's a problem between the adhesion of the epithelium and the stroma due to an abnormal presence of the hemidesmosomes, which are those attachments between the epithelium and the stroma. Those are abnormal, so that means that the epithelium grows but is not attached to the stroma. And with each blinking, the epithelium moves, and again, you have another ulcer. So the clinical presentation for SCETS are very different. You can have all these different presentations. Look at that. All this epithelium was not attached. So if you remove with a cotton swab, you will have an ulcer of this size. Then you have to explain the owner what spontaneous chronic epithelial defect is, and then that you need to approach the problem in two ways. One is surgical, and another is medically. That at home they will need some topical drops, but here we need to do a surgery under topical anesthesia. Normally, we perform all these surgeries under topical anesthesia, and we will start with a manual or rotatory debridement, normally with a rotatory debridement with the diamond burr, and then we will place the bandage contact lens. We start with the cotton swab, we eliminate all the margins, and then we will go with our diamond burr to remove all the margins of the ulcer, but also to go to all the ulcer bed. It's very important because we will remove the more superficial areas of the stroma, which are the affected ones and the ones that are not allowing the growth of new emitesmosomes. Normally with this procedure, we have a really good success of 90-95%, and it can be performed up to 3 times. After the debridement, we use corneal bandage lens, and they work really well. If you perform this debridement for 3 times and it doesn't work, you can go for a grid keratotomy. I remember when I was a resident that I was performing grid keratotomies very often, but since the diamond burr was commercially available, I have not done anymore at all grid keratotomy. So I think that I have to explain, but normally it's not used in our daily basis. The grid keratotomy consists on performing very mild incisions with a needle on the cornea after removing all the epithelium with a cotton swab, and those incisions have to be very superficial. You see this histopathology section, and how these incisions, what they do is that the corneal epithelium insert in the stroma. So you have like different fixation points that will allow the epithelium to be adherent to the stroma. And those incisions have to be very superficial, because if they are not superficial, then you can have those results, and this is hopeful, completely hopeful. This is horrible, but this is hopeful. This case arrived to Dr. John Sapienza for a second opinion, and this is very difficult to fix. So we have to be very superficial. And with both surgical approach, we got really good results. There are different papers comparing the debridement with the diamond burr and the superficial grid keratotomy, and the results are really good. But I think that we need to go for the less invasive surgery, and in this case is the diamond burr debridement. And then if you don't have good results, you can move into superficial keratectomy. Again, I have not done a superficial keratectomy for treating this kind of ulcer for 10 years. So it's very rarely seen, but you have to know that you can do this surgery. You remove the completely superficial area, you place a corneal lens, and you allow to heal by secondary intention, but you will have some scar as you are inducing stromal ulcer. The medical treatment. So you will explain the owner, you will explain the different steps that we can perform, and you will start with your debridement. You will place the lens, and you will explain the owner that we will start treatment with antibiotics. And for these kinds of ulcer, it has been described the use of tetracyclines. It will help to induce new emitesmosomes. Cycloplegic, again, atropine or cyclopentolate, artificial tears. You can choose based on our table. Soft non-steroidal anti-inflammatory drugs. You can use them if you think that it would help because you have a lot of edema, or because it will allow a slow healing. And if you have a slow healing, they have more time to attached to the cornea. So we normally use non-steroidal drugs in those kinds of ulcers, but one or twice per day, and those that are very soft, not very powerful. And then we can use other topical drugs. In fact, there are papers talking about the use of heterologous serum for this kind of ulcers, but they say that there was no improvement on the reepithelialization of these ulcers, so we normally don't use them. And also there are papers talking about the use of aminocarboxylic acid, and they say they work, is another option. You can also use vitamin A if needed, or anti-edematose drugs if you see that there's an important edema. And of course, the Elizabethan collar and the bandage lens. Those are very important. There are different papers talking about the use of bandage lens and the types of bandage lens to use. In my experience and in some papers, they describe that the use of corneal bandage lenses after debridement or after agreed keratotomy helps in terms of less discomfort and helps in healing. So I think that for me it's very important the comfort of our patients, and if it also helps in increasing the velocity of healing, it is perfect. And we have talked about two different lenses, and there's a paper that compares both lenses, and it says that in this paper that the lens by the human lens pure vision remain more time in the cornea than the other lens. So you need to know which lens are you going to use. Normally, if the ulcer is very big, we go for Envision lens. But if the ulcer is smaller, then we go for human bandage lens. So the take-home message from this kind of ulcer is that an early diagnosis is very important. If you have doubts, use a cotton swab. Look for the cause always. If there's a systemic disease, for example, diabetes mellitus or hyperadrenocorticism can be the cause. The age is another important fact. Normally, older dogs can have more often those kinds of ulcer. Breed predisposition, brachycephalic breeds, Boxer was the first breed in which this disease was described. And then the surgical and medical treatment, that the gold standard treatment at this moment is the diamond bore debridement plus the bandage corneal lens, and it works really well in our hands. And then normally those corneal ulcers have good prognosis. So we perform the diamond bore debridement. We start with the treatment and we check those animals in 1 week. And we debride again if needed, twice or 3 times. We remove the lens, we debride, and then we place again the lens. Case number 6 is Nami. He's a Maltese male. In this case, there was a fight with a cat 2 hours ago, and you see the neuro-ophthalmology is everything normal except for the fluorescein stain, and you see that this cornea has a corneal laceration that is not full thickness, but we see this laceration in here. So we have 2 options. Or we cut this, that means that we will have a corneal scar because we are going through the corneal stroma, or we replace this flap and we suture, is what we did. So talking about corneal lacerations, it is very important to perform a complete ophthalmic examination and to make sure that there's no lens affection and that the retina is in place, at least that you have venous response, nasal reflex, or pupillary light reflexes, direct or indirect, to make sure that everything is okay and that you're going to suture a cornea in an eye that has possibilities to be visual. So this is very important. And if the lens is affected, then you have to go for lens surgery at the same time of the corneal surgery, and this is a more difficult surgery. Normally, we recommend lens surgery if the lesions are bigger than 1.5 millimeters. This was described by Dr. Davidson many years ago, and for us, this is the cut point. If the section is bigger, then we go to surgery. If it is smaller, then we treat medically. So when we are suturing a defect, there are different things that we need to consider. One is the wound section. If it is perpendicular, this is very simple to suture. Well, very simple. Those are the simplest ones. So when you pass your suture, you have to be equally the section in this area and in this area. But when the one section is oblique, then things are more difficult, because if you do the same area in here, you will have a tissue override. So what you need is to have the same area, but not in the upper part, in the lower here. So when you pass the suture here, there will be the middle. So you have half here and half there, and then you will have a perfect apposition. And this is very important. Okay. And then apart from the one section, the size, the bigger was prognosis, the shape. Some of them are very nice and others are more difficult. And the iris prolapse. If the iris is viable, we will keep the iris. We will reintroduce with viscoelastics, and we will keep the iris to use some hydratic drops, and we will keep the iris in there, but perhaps some TPA to avoid fibrin formation. But if the iris is not viable, then we will go for an iridectomy with the bipolar cautery, and then we will suture the cornea. This is a ferret with a corneal perforation. So the take-home message from this paper is that we need a complete ophthalmic evaluation previously to corneal suture. We need to make sure that this eye will be able to recover vision. To rule out other intraocular lesions, doesn't make sense to fix the corneal problem, but then to have a phacoclastic uveitis at that point. And then to establish the vision prognosis is very important. Look for the basal reflex to the indirect pupillary reflex if you don't have menace or you don't have direct pupillary reflex. And then the corneal treatment is the gold standard. But for this, we need an experienced surgeon under the magnifying microscope, surgical microscope, and you need really good surgical skills. Case 7, we have Choco, is a French bulldog male, 5-year-old with a chronic corneal ulcer. You see that the Schirmer-Chia test is okay. Neuroophthalmology was okay, except for a dyschorrhea in the left eye. The intraocular pressure was okay. And then the fluorescein stain. And you can see how in this eye we have very deep corneal ulcer with some fibrin formation. That means that this eye has been perforated with the anterior synetia. So we have a corneal perforation. In Barcelona, our protocol under a deep corneal ulcer or corneal perforation, we need to decide what kind of surgery we are going to perform. And we take this decision in base of the species, the age, the general condition of the animal, and the character, if it will allow to apply medication six times daily for a very long period or not, the lesion and the severity of the lesion, the size, the depth, and the location. If we have concurrent ocular diseases such as KCS or severe keratitis, and the owner, of course. Some surgeries are more expensive than others, and if they can apply medication for long periods of time. If we are going to perform a keratoplasty, then the prognosis, the post-operative period is going to be longer. So we want to make sure that the owners understand the importance of the topical medication. Doesn't make sense that I do a perfect surgery and then the owner do not apply the medication as we prescribe. So in this case, the owner went for a corneal graft for a keratoplasty, and the results were very nice in this case. We are still under topical corticosteroids. Then we want to talk a little bit about fresh and frozen keratoplasties. In Barcelona, we have our eye ban, and we have eyes from different origins, so we can perform allografts and heterografts from the same species and different species. And then we include eyes from animals younger than 6 years with non-infections or non-neoplastic diseases. And we perform a slit lamp ocular examination, and we enucleate those eyes within 6 hours after the death. So we can use those eyes in a fresh mode. That means that we want to keep those eyes for 24 or 48 hours. Or we want to store it. We normally store them in a conventional freezer. And in both situations, whether we are going to use in fresh or frozen, The conservation method is the same. So we want to use this small bottle with gauze at the bottom, and then the eye is with some sutures that keeps the eye in a correct place. And we're going to introduce some triple antibiotics in here, and we want to close the recipient. So in this way, we're going to create like a humid chamber, and we can keep this eye in the fridge for more or less 2 days approximately. We can use it in fresh. That means that we're going to do grafts to the same species, to the same species, or we want to keep in the freezer, and that means that we can use this eye for different species. So again, fresh for allografts, frozen for different species. And from the frozen cornea, you have to remember that the endothelium and the epithelium is completely dead. So you are just giving collagen. So you can use collagen from pig eyes to dogs or cats or horses or whatever. So we normally use pig eyes. And as the transparency comes mainly from the endothelium, if you have a problem in the eye, but you can keep the endothelium of the donor eye, then there's no need for a fresh graft. You can use a frozen graft. If we compare both grafts, the fresh graft have more possibility to rejection than the frozen one. So our way of working is that always that we can perform a frozen graft, we go for a frozen better than a fresh, because a fresh has more possibilities to be rejected. But if you need to perform, for example, a full thickness keratoplasty due to an endothelial disease, then you need to go for a fresh, because you need fresh endothelium. But if you are going to do a keratoplasty after a superficial keratectomy or a middle keratectomy, then you can use a frozen tissue, because the endothelium is in the donor and is healthy. So the indications for anterior lamellar keratoplasty are different, but the most common ones are deep ulcers or corneal perforations. So first you measure the lesion size, you prepare the donor tissue, always 0.5, 1 millimeters bigger, and you perform superficial keratectomy, or you prepare the receptor bed in this case. So we have a corneal perforation. You can see that there's some fibrin in this cornea. We prepare the bed, we remove the epithelium, because you don't want to put your graft and allow the epithelium of the donor to under growth the graft. So we remove all the epithelium in this area, and we remove all the fibrin. You have to be careful, because sometimes the hole in the endothelium is not so big. Perhaps it's a small hole, and you don't want to remove all the endothelium. The most endothelium that you can preserve, the better. So you remove as much fibrin as possible, and vessels and cerebral infiltrate. You make sure that there's no anterior synechia. If there's an anterior synechia, you need to remove. You can see how we have eliminated all the epithelium around. And then we harvest the bottom for of the donor, and we fit the corneal bottom in the receptor bed. In this case was a lamellar. So you have seen how to produce a lamellar keratectomy with the corneal sequestrum video. So you do the same with the frozen eye, 1 millimeter bigger, 0.5, 1 millimeters bigger, and you start suturing with the epithelium up. Normally you remove the epithelium before, because it's not alive, so you remove it. And you place some cardinal sutures, and it's very important to place the graft in the stroma, not in the epithelium, because you need the epithelium to overgrowth, not undergrowth. Look at these forceps, are very nice. Those are Pollack forceps that help to place the graft. And then sometimes it's not completely rounded, so you need to fit the corneal bottom in the receptor bed with scissors. and you have to be very careful because you want a nice result. In this case, you can decide if you want to remove more fibrin of the ulcer bed or not. The problem is that if you remove more, probably you will remove the endothelium, and this area going to be opaque. But with the medication, all this fibrin and all this cellular infiltrate will disappear. So there's no sense on going deeper if there's no anterior synechiae. And then we suture the graft. We place cardinal sutures, trying to be very gentle with the cornea. You place 4 and then you place the rest. Normally we use non-absorbable sutures. In some cases we can use absorbable depending on the animal, but normally non-absorbable. And you try to place the sutures to avoid any leakage of aqueous humor. And make sure that there's no epithelium of the donor underneath the corneal graft. This is very important. And the knots, as you have seen, are always in the donor tissue, not in the receptor. Because if you place the knots in the receptor, normally they are closer to the limbus, and you have more possibility of rejection. So with these surgeries, you can have such a nice results in this case, for example, and you can see how the tissue that you have grafted is completely fluorescein positive the first days, but the epithelium starts overgrowing, overhealing, and you will see how the ulcer is smaller and smaller and smaller, and at the end completely transparent, and then completely transparent in this picture. But it's very nice because you can see how the epithelium goes and covers. And then similarly, we can have frozen full thickness keratoplasties. If you cannot, for example, maintain the endothelium. So you can see that we are removing the epithelium 1 millimeter bigger than the defect. We place the graft with some viscoelastic and we keep it prepared. And then we prepare the bed of the ulcer. We have done this in this order because we think that there's the possibility of corneal perforation while we are touching the cornea, and we don't want to have problems. So we check that the size is correct, and then we keep on going. And you see that there's a corneal perforation, but now we have the graft prepared and ready. We are removing anterior synechias. And you see that we want to keep the endothelium. There's no reason for eliminating this endothelium. The endothelium is okay. There's just a small corneal perforation. If we keep the endothelium, this graft will be transparent. Okay, and we place the graft. Cardinal sutures and the rest of the sutures, with the knot always in the donor, not in the receptor. Okay, so we have very nice results at those ones. Of course, you will have fibrosis, but look that this fibrosis is that one. It's not from the graft. So those eyes in another places probably they will get enucleated. In our hands, we can give an option. And in this cat, it was very nice because it was completely blind, and we perform a frozen graft. And after 2 years, we changed the frozen by a fresh graft, and both eyes were visual. And this animal was completely blind. Another option is the conjunctival transposition. I think I'm going very late, but let's see if I can finish. Conjunctival transposition is another option. So what you are going to do is to advance conjunctiva and cornea to the area of the defect. So you can decide whether if you are going for a corneal graft or if you are going for a CCT. So you advance cornea and conjunctiva. This is a very small video. For example, what we do is, if the lesion is very small, we do a CCT because the post-op is very quick, it's very short. But for a corneal grafting, for a keratoplasty is longer. So for us, it makes sense to have a longer post-op if the lesion is very big and you cannot fix the problem with a CCT. But if you can save the problem with a CCT, we go for it. And you can see how we do a lamellar keratoplasty in here with a crescent blade. And once we have the tissue ready, the cornea and the conjunctival tissue ready, then we prepare the bed of the ulcer just to make sure that we don't have corneal perforation and the tissue is not ready, just to cover it. So the bed is the last part that we prepare. So we remove the edges of the ulcer. We do a square area. Always very gentle, managing the cornea. And then what we're gonna do is we're gonna advance the cornea and we're gonna suture. In this case, with absorbable 9O suture material. We always use 9O or 10O. Okay, so we place these two sutures, the first one at the edges, and then we normally do 2 continuous sutures or simple sutures, as you prefer. So you place those. The last, and then you place a continuous suture here, here. And we have also published a paper with this technique. Was the first paper that was published with the use of CCT in dogs. And we have really good results, as you can see, and a very short postoperative period, perhaps 3 or 4 weeks. It's incredible. Such a nice results. So in our hands, if the ulcer can be fixed with a CCT, we go for a CCT. So the surgical treatment of a corneal perforation of a deep corneal ulcer has to be performed by an experienced surgeon. And there are different options that can be discussed with the owner. And then we will apply different specific medical treatment according to the surgical treatment applied. That is completely different. And then the last case of the day is Churro. Is a mixed dog, 5-year-old male. And then you can see how he has a chronic corneal ulcer in the right eye, the left eye. Seems to be right, has to be right. So right, that means that the shear material test is wrong, 25 on the right eye. The neurophthalmology was completely normal, but in this eye, the direct pupillary reflex was slow, and the indirect of the contralateral eye also was slow. The aqueous flare seems to be positive, but it's very difficult to see because we have a diffuse corneal edema. The intraocular pressure is very reduced, it's 10 millimeters, and in the other eye is 19. That means that we have an anterior uveitis, and you can see the ulcer is completely stained with fluorescein. That means that at least it's predystematic or stromal, but it seems very, very, very deep. So it's predystematic, deep stromal predystematic. And you can see that there's cellular infiltrate, and this aspect looks like infected or melting. Keratomalacia. So the melting ulcers can have very different presentations. You know that the melting ulcer means that the collagen is being digested, that is keratomalacia. So we have this equilibrium between the collagen and the collagenasas. So we have more collagenasas than anti-collagenasas, and then the collagen is completely digested. That means that it's an ulcer that appears very quick and goes very quick. So we have hours to try to fix the problem. And normally they are associated with very severe anti-uveitis. And there's a very typical appearance. You can see how the cornea is very soft, and you can even touch with a cotton swab and will move. It's very edematous. In those cases, always when you think that there's an infection in the cornea, when there's a melting ulcer, when there's a cellular infiltrate, go for a cytology and make sure that there are no fungal or neutrophilic infiltrate, because remember that the melting ulcer can be induced by fungal, but also by bacteria and by neutrophiles. So it is very important to have a cytology to decide which is going to be our medical approach. And of course, a culture, but the culture will take 5 days more or less. And we need to start the medication as soon as possible. So our medical approach is always antibiotics. We will decide the kind of antibiotic depending on the cytology. So we normally combine 2 types of antibiotic, triple antibiotic and acid and fusidic acid with aminoglycosides or fluoroquinolones. Or you can use also tetracyclines, but because this antibiotic at the same time has some anti-collagenase effect. And then we can have cycloplegic drugs, atropine or cyclopentolate, artificial tears, of course, non-steroidal drugs, topical. We will use it because they are cellular infiltrate, and we will use more non-steroidal drugs if we see a severe infiltration of neutrophils. If we see less severe, we will use less anti-inflammatory drugs topically. Then anticollagenase drugs is the most important part of the medication. So we can use different kinds. We can use EDTA, we can use autologous serum. We normally use autologous serum. You can use tetracyclines, you can use N-acetylcysteine, Ilomostat, or you can use the Vetrix amniotic eye drops that it seems to work really, really well. Normally we apply 6 to 12 times per day. That means every 2 hours, more or less. So normally we keep those animals with us to see how is the evolution, how it goes for 12 hours, and then we decide whether if we go to surgery or if we keep with the medication. Then apart from the topical medication, we add systemic antibiotics and systemic non-steroidal drugs, and of course the Elizabethan collar. There are other medications that you can apply. Of course, if you see fungal organisms in your cytology, you will give voriconazole, or you can give vitamin A or, as we have said, amniotic drops. If in 12 hours the ulcer is deep or it worsens, then we go for surgery. And some years ago, I remember that I was trained in the way that all the melting ulcers were treated surgically with conjunctival graft. Since many years ago, there's no conjunctival graft anymore. It's very rarely for us to perform a conjunctival graft. And we do amniotic membrane inserts. And we all know that the amniotic membrane has anti-inflammatory proteins, anti-angiogenic proteins, and is plenty of proteins inhibitors. And that is the most important thing for us. So it will control the collagenolisis of the cornea. And also it's non-antigenic because there are very few cells. So you can use from different species in the cornea of a dog, of a cat. You can use equine, you can use human, you can use of other species. And the surgical technique can vary depending on your kind of surgery. You can use one layer, multi-layer. You can use with the epithelium up or down. If you want to integrate the amniotic in the cornea, then with the epithelium up. But if you want just to act as a bandage or protection with the epithelium down, you can cover just the defect, as seen here, or you can cover the defect and also the complete eye with sutures to the limbus, or you can do both. Here you have both, one in the defect and another to the limbus. So you can use both. Again, we published a study on the use of amniotic membrane in dogs with very nice results for complicated corneal ulcers in the dogs. So you see that the amniotic membrane can be has different kinds of presentation. It can be lyophilized. Normally we don't use it, but we use this that comes with this presentation that is frozen. So you prepare the bed of the corneal defect. In this case, it's a melting ulcer in here, and you decide whether, if the defect is very deep, you need 1 layer, 2 layers, 3 layers, because in fact the amniotic membrane is very thin. So you decide, in this case, we decide to do 1 layer. So you place the amniotic membrane, you make sure that the epithelium is up. If you touch with some surgical sponge, you will see that there's no adhesion. If we touch in the internal part, there's an adhesion of the tissue to the surgical sponge. So that makes you sure that the epithelium is up and not down. And then we place the cardinal sutures again, as we have seen with the keratoplasty. And then the rest of the sutures. In this case, with the amniotic membrane, we place absorbable sutures because we don't want to remove them. And we place the sutures, and we have this result. Keep on suturing. And then you keep with the medication. This is very important. You have the amniotic membrane in place, so they will give you some anticollagenolitic effect, but you have to keep with the medication, perhaps not every 2 hours, but at least 6 times per day. And we have such a nice results. And also the amniotic membrane can come with the chorion. That means that it's thicker. Like in this case, we use this chorion amniotic membrane, which is lyophilized. And you have really good results. Look at this eye, it's very awful. And the eye finally was completely visual. The results are very nice, honestly. And you don't have a corneal graft in the cornea. So in summary, if you have a simple ulcer, we will start with treatment for 72 hours. If it goes well, perfect. If we have complications, then we will try to know which is the complications that we have. Then if we have a SCED, we will do the special treatment. If we have infected melting ulcer, we will start with the medication, intensive medication for 12 hours more or less, 24 hours. And then we will decide if we go to surgery or not with an amniotic membrane. Or if the ulcer is deeper than mid-stromal ulcer, then we'll go for surgery. And in our hands, that means our CCT or amniotic graft. And if you have an ulcer that is anterior stroma or medium stroma and the owner doesn't want to go for surgery, we will do the same medical treatment as for a melting ulcer, but perhaps with less anticollagenetic medication, but with the same combination of antibiotics, cycloplegic, artificial tears, systemic antibiotics, and non-steroidal drugs, because normally those ulcers are associated with anterior uveitis. So in these 2 lectures, we have gone through, I think, the most common corneal diseases, but of course there are plenty of others that we have not talked about. Corneal dystrophies, corneal degenerations, PPMs, melanocytomas, limbal melanocytomas, 4-inch bodies in the cornea, corneal tumors, bullous keratopathy, and many others, but perhaps in another lecture. So I would like to thank all of you that have been sharing with me these 2 hours of lecture. I hope that you have enjoyed. And of course, you can contact me whenever you need any support. You have my email here, and I will be more than glad to help you if I can. So thank you.
Thank you very much, Dr. Marta. That was very informative, and I'm pretty sure you're very, very tired after talking for 2 hours non-stop. We have a lot of questions. I've kind of tried to keep them as less as possible. So one of the questions was about, there were a couple of questions about bandage contact lenses. Do you basically, I think there's a little confusion about how do you fix them? Do you fix them? Do you take a suture? And do you do, how do dogs tolerate the bandage contact lenses?
The bandage contact lenses, they tolerate perfectly. I mean, they don't realize that they have the lens in. And the thing is that we only do tarsography here, a suture in the eyelid, lateral tarsography, when we do corneal surgery under general anesthesia. And we have a very extensive ulcer, and we put an envision lens, and we want to make sure that the lens is going to be there for 10 days. Then we place the lens and we do lateral tarsography. But in the other cases, in which, for example, in your visit, you do a diamond burr debridement in a spontaneous chronic corneal epithelial defect, and you place a lens, you don't place any kind of suture. You place a lens, and that's all. Normally, when they come back, the lens is in place. But if it is not, no problem. But the thing is that perhaps it's my impression, but it has been demonstrated in papers that the degree of discomfort it's much less. So for me, it's worth to try and put the bandage edge. It's very easy.
Now, after superficial keratectomy for pigmentary keratitis, or even doing after the diamond burr, which topical medications do you use, and how long do you keep using them?
Well, in fact, you will keep this medication until you have a fluorescein test that is negative. So we will start with broad spectrum antibiotics, triple antibiotics, 3 or 4 times daily, cyclopentolate 2 or 3 times per day, artificial tears, and non-steroidal drugs plus the cyclosporine, Optimium if you want, and the pens. And then once you have a fluorescein test that is negative, then you move to the regular treatment that is going to be topical corticosteroids and cyclosporine. If you want to keep for some days artificial tears, is okay.
Okay. Now, do you use serum for corneal ulcers which are not melting? So any kind of corneal ulcers?
No, we don't. I know that there's some people that do, but we don't. We try to diminish the medication as much as possible and only use the medication that is indicated. I know that people give some even antifungal drops if there's no fungal in the cornea. For me, it doesn't make sense. But I know that some people feel more comfortable with plasma. At least I know that there's not negative effects. If they feel more comfortable, they can go. Normally, we apply plasma to the melting ulcers and to ulcers in very old dogs, perhaps, or in dogs with diabetes or with other systemic diseases. But as a regular basis.
Okay. Now, in pigmentary keratitis, when you do a medial canthoplasty, do you always do the diamond burr? I mean, do you always do keratectomies, or after medial canthoplasty, does the pigment vanish automatically?
It depends. It depends. Normally, after the medial canthoplasty, you'll have some improvement, or at least there's no worsening of the pigment if you keep on with the medication. It's not that you do a medial canthoplasty and you forget about the topical medication. But we combine surgeries when you have been treating the eye for some months and you have seen an improvement, but there's one point that this improvement has stopped and there's a lot of pigment. So we have a stage 3 in this pigmentary keratitis, and you know that even if you fix the eyelid problem, this pigment will not be absorbed at all. So I'm not going to remove the pigment of a cornea in a stage 1, but yes, in a stage 2 or stage 3.
Okay. Do you use cryotherapy for pigmentary keratitis?
No, we don't. Sorry.
Okay. Have you ever had a melting ulcer after diamond burr?
Yes. It's very rarely seen, but when you have one, you never forget. And I remember two cases. I have seen 2 in my life, in all my career. I see, I don't know, 20 of those ulcers per week, but I have 2 melting ulcers after diamond burr. And I don't know if it was me, if it was the diamond burr, the sterilization process, or whatever, but I have 2 melting ulcers.
And how do you sterilize the tip of the diamond burr?
Well, in fact, there's a study comparing two types of sterilization. One that is quick, that is a germinator, and they do not recommend this kind of sterilization. That is it's very comfortable for us because it's just 5 minutes, 10 minutes, and it's okay. But they have seen that there are some infectious particles in there, and they recommend the autoclave all the tips. So you have to wash with ultrasound. So one use per patient.
And how long do you use the atropine after diamond bar, or if you have a ulcer, how long do you keep using atropine drops?
Well, in fact, we don't go for atropine. We normally go for cyclopentolate because there's no reduction in the Schmidt test with this drug, and it is nearly as much potent as a cycloplegic as the atropine, but with no side effects or less side effects. But we keep those cycloplegic until the ulcer is completely fluorescein negative. What you can do is start with a postology of 2 or 3 times per day in the case of cycloplegia, in the case of atropine twice per day. And as soon as you see that the ulcer is reducing, you can reduce the cycloplegic drug until you completely stop when the ulcer is fluorescein negative.
Okay. And there's one question about why is ketorolac considered as soft NSAID?
They are not. Why they are soft non-steroidal?
Why is it considered as a soft non-steroidal?
Yeah, because there are different studies that compare the efficacy and power of the different non-steroidal topical drugs, and those are considered as non so powerful. But epafenab, for example, is one of the most powerful nowadays. Of fluoroibuprofen, those are the most powerful. With bromfenab also. So you have like a degree of power in a non-steroidal drug as you have it with corticosteroids, and those ones are ones of the less powerful ones. So if you want some anti-inflammatory effect that do not reduce the healing of the cornea really markedly, you go for a soft non-steroidal drug.
Do you use amnion drops for stromal ulcers? Not the melting one. I mean, melting ones you explained, but for stromal ulcers.
No, I don't, but I think that it would be a good option. It depends on the owner. If the owner wants to apply such a different drugs, for me they are not needed. But I'm sure that they are not going to be negative for the ulcer treatment. So you can use them if you feel more comfortable. Remember that when you have a deep ulcer or medium stromal ulcer, you have to recheck the patient every 2 days because things can change very quickly.
Okay. And there's one question about which graft material would you use for perforation in case of transplant is not possible. But I think you have already answered in your lecture.
Well, I think you can go for a CCT if it is small, or I will go for if it is a really corneal perforation, probably with a biocyst or with amniotic with chorion. So you need a thick tectonic support. So those would be my options, my surgical options, if there is no possibility for a donor eye.
And which is your best antibiotic of choice, or antibiotic that you go to in your practice for corneal ulcers or conditions?
Well, it depends on the ulcer, but we normally start in a simple ulcer with tracheal antibiotic or fusidic acid. And if we have stromal ulcer, we can go for a ciprofloxacin or tobramycin. But remember that the ciprofloxacin is perfect because it penetrates really well in the cornea and even in the anterior chamber. But the problem is that the healing is lower with the ciprofloxacin. So you need to consider this. You can also use gentamicin in case you need it. Again, there's a slow healing with gentamicin, or tobramycin is really nice. Or you can combine both if you think that you have different kinds of microorganisms in this cornea based on your cytology.
I think that's it. I mean, I won't continue asking because there will be more questions. That was an absolutely wonderful session. That one of the slides had this wonderful Elizabethan collar on this beautiful hound. greyhound. Where I mean, that is quite well designed, Elizabethan collar.
Yes,
I'd love to have a hands on those kind of collars.
yeah, it is very nice, and also for those animals with big ears, it's very nice.
Yeah, it is very, very nice, and they can eat as well. So that is very nice.
It's commercially available, so you can buy.
Yeah. So thank you very much, Dr. Leva, for such an informative and amazing lecture. And I thank the Anvision team and Team Catalan for organizing this wonderful webinar. And yeah, wonderful.
Okay, thank you.
Thank you.
Bye.
Bye bye.